Well, Dr. Youssef Elgin Jihi is a GP in the London Borough of Tower Hamlets and author of How to Dismantle the NHS in 10 Easy Steps. And Dr. Graham Jackson is co-chair of the NHS Clinical Commissioners. He's also a practicing GP and chair of Aylesbury Vale CCG. Good afternoon to you both. I should point out, Dr. Youssef, that the title of your book is a slightly ironic one, but just explain how it works in your own practice. How do you go about prioritising appointments?
Thank you. Well, yeah, it's very much a tongue-in-cheek title. I mean, obviously we prioritise appointments according to urgency usually, and I think as the chair of the Royal College has pointed out, the more routine appointments are now being delayed with difficulty for patients getting appointments, longer waiting times, and we're seeing that picture of what I call a manufactured crisis across the NHS.
How many patients would you see on average a day then?
Well, I mean, currently I've actually been on both sides, so I've been a patient and I've therefore had life-saving treatment from the NHS in the past year, and I'm on sabbatical right now. But when I was working, I mean, a typical GP would be seeing something in the region of up to 40 patients, plus obviously paperwork, administration, and so on.
Is that 40, sorry, you said? 40?
Yeah, 40, but obviously it varies. Some places they will see less or more. There'll be also phone appointments, sometimes home visits, depending on your role. So there is huge pressure in the system, and for GPs, there's real burnout because of this underfunding, underinvestment that's going back to the previous decade. As a result, there's a significant recruitment and retention crisis.
And despite seeing 40 a day, how many would you have to see a day to keep waiting lists at a reasonable time?
Well, it depends obviously on the kind of organisation and structure of each GP surgery. So there will, for example, be a duty doctor or an on-call doctor who will deal with the more urgent problems, and that can obviously be very variable from a relatively normal session to a session which is extremely difficult to handle. Certainly the experience in Tower Hamlets, and I would imagine across the country, is that appointments get booked up very, very quickly, very early on in the morning. And often, as Dr. Stokes-Lampard has said, it may be difficult to access an appointment for days, if not weeks.
Well, let's get the views from Aylesbury Vale. Dr. Graham Jackson, how bleak a picture is this?
Good afternoon. I agree with much that's been said so far, and Helen Stokes-Lampard's comments about the stretch service are very true. However, I think that we know that there's a problem with crisis and recruitment, so we need to be thinking differently how we deliver these services. One of the things that I see in my practice is that we see a lot of patients who actually may be better serviced by a different healthcare professional, or in fact having a greater level of confidence in self-care. So although Helen's talking about things that become urgent after being delayed, there are also things that are self-limiting. And that's all mixed up in this melee of delay that we're seeing.
So when you talk about self-care, Graham, are you talking about going to your pharmacist, searching in the back of the medicine cabinet and getting out the cough medicine that
internet
you haven't
searches?
Used? Well, yeah, internet searches, you know.
Yes,
I mean, but we're all being told the whole time not to trust the internet searches.
Well, there are some very good internet searches, NHS choices, etc., patient-facing services. But I mean, I think there's an element of all of that. So I think it is very difficult for patients to navigate, or population to navigate the service, and we need to make that easier for them. 111 Dusk will give advice as well as direct people to urgent care services. Hospital community pharmacists are a fantastic resource. They have a great deal of knowledge, and people often bypass them. But even when people are in the health service, we maybe don't use our assets as best as we could. So our personnel, some of our nursing staff are, they're being underused for their skill set because they've got much greater experience than people realise. We've become very GP focused, I think, and I do worry that actually that increases the workload, but not necessarily increases the best outcome for our patients.
Yusuf, what do you think about that? Are there people who just shouldn't actually be turning up in the surgery?
So I think we have to be very careful here. Of course, we need more patient education, and where self-care or pharmacy care is appropriate, that should be encouraged. But what we have to be careful about is that self-care and pharmacy care is now being used as a substitute for high-quality medical and nursing care. And I'm glad we've come on to this subject about care in the community, because what we're seeing now is a program of what's known as integrated healthcare being pushed, which is to try and deliver care instead of in hospitals, in communities, except the problem is that integrated healthcare is a US healthcare concept, and I think we have to be very worried about that in the context of wider privatization of our NHS. So some very worrying things here when we look at, for example, the current sustainability and transformation plans that have received quite a lot of coverage in the media over the last few months. That's very much about this US model of integrated healthcare, and that's translating into, so far in the past, since 2010, we've seen over 650 GP surgeries close, merge, or get taken over, and now the Royal College is saying that somewhere between 500 to 600 are threatened with closure by 2020. So that's a very worrying picture of closures and cuts, which ties in with privatisation.
Well, this is an issue a lot of listeners understandably feel very passionate about. Dr. Graham, let me put a text message from Richard to you. Luke, if a GP can see a patient in 4 weeks' time, surely they can see them in 2 days. It's the same amount of work, except for people curing themselves or dying. My local doctor does walk-in every morning and appointments in the afternoons. What would you say to that?
I would say that the model of how it's delivered across the country is very different. It is about the access within the healthcare team that is locally, depends on the demography. It's very difficult to judge a particular service based on an example. And I think Helen also implies that actually across the country the access is very different. So I think that the integration transformation piece that has been mentioned actually is more than a US model. It's different from a US model. But actually using the assets, using the staff differently. So, I mean, a nursing team that works across the community and into the hospital, into primary care, so it actually makes it easier to shared services and shared delivery. There's different ways of thinking and with our current workforce. Now, I'm not saying the workforce is not sufficient enough. I'm saying that we have a workforce that we have to work with at present. And as everyone implies, training new doctors and nurses takes quite some time. So we've got an issue now. We need to think differently and deliver our services more effectively, more patient-facing for better outcomes.
But the ultimate fear, I'm sure, Graham, and for you, Yusuf, as well, is that somebody listening to this who's thinking, yeah, I've got this lump, it's Christmas, I'm not going to worry my doctor about it at the moment, maybe I'll try and make an appointment in January, and then it just kind of gets lost because that lump could be the indication of something very, very serious underlying. Graham, what do you say to somebody who's thinking like that at the moment?
Absolutely. I think that if there is an issue, and you take that as an example, then they do need to seek help. And that's why there's sometimes these the talk before you walk services. You ring 111, you can talk to a GP often, get advice, take the history. The detail of the story behind the lump tells a lot to the clinician about the potential of that being more serious or less serious. And actually that kind of person that may need to be seen quite expediently, come in quite soon and be examined. But not everyone is presenting with that sort of story. So you need to realise across the whole population there's a myriad of presentations, and there's a number of different outcomes that could be delivered to the population. And
this final text to you, Yusuf, from Bernard in Newcastle, who says, why don't people unable to arrange a GP appointment ring NHS 111 and use this inquiry to either have a nurse and or a doctor phone them back, depending on the NHS 111 results? They can be armed with evidence of a requirement to see a GP.
Absolutely. Again, telephone consultations or care is an alternative where appropriate. But I'm glad again we've mentioned NHS 111 because that's a very good example of privatisation where we've seen a service that was previously working relatively smoothly as NHS Direct has become NHS 111, and it's been parcelled up, as far as I understand, through competitive tendering into various contracts, and has therefore not been working, has been very fragmented and hasn't been working anywhere near as smoothly as it should do. So we have to really revisit the issue of the NHS becoming a market system and being privatised, which is sucking a lot of money out of the system, and we need to very seriously look at restoring it as a publicly provided, publicly run healthcare system.
Thank you very much, Dr. Yusuf Elginjihi, GP in the London Borough of Tower Hamlets, and to Dr. Graham Jackson, co-chair of NHS Clinical Commissioners.